Well, once again, I'm excited to speak at the focal meeting. This time we moved to Chicago, it looks like, from last year in LA. I want to thank the committee for this opportunity to speak. Unfortunately, I can't be with you all. Our clinical team got hit by COVID, including myself. Although on the mend, not really safe to travel going forward. So doing this virtually, but sad to miss out seeing my friends, colleagues, and all my former trainees, students, residents, and fellows who were there. Disclosure, I'm a full-time employee of the U.S. government, and in doing so, my colleagues and our partners in industry took from concept to commercialization the urinary biopsy platform. I'm also on the AUA prostate cancer guidelines committee. We just published our prostate cancer screening guidelines this past spring, and no other disclosures. I want to acknowledge my fellow Neil Mandarita. Very fortunate to have another great fellow going into this field. And then, of course, we have a medical student, Sahil Parikh, who's been excellent, applying for urology. For those in the audience who have residencies, keep an eye out for Sahil. He's just fantastic. Thank you for your help in this presentation. So looking back, I left Hopkins as a fellow, finished up in 2003, came to NIH. This is my 20-year anniversary, and it's fitting that I'm giving this lecture on fusion biopsies because I was given unsolicited advice by a mentor who said to me, Peter, of my institution, the MRI in prostate MRI stands for magnetic resonance imagination. What are you doing with your career? And I said, well, this is an unmet need that's important, and I think a lot of folks back then didn't really believe in this. So look where you are today. And the reason why is that for decades, we were just happy as urologists, poking the prostate, hoping to hit the cancer, never knowing if we missed it or hit it, or what the extent of it was, and it was done blind. And, we can keep poking away if you want, but really this was something that we needed to move on from, and research in this field has changed how we practice medicine. When MRI came about, as you heard earlier this morning, gave us the opportunity to see where the tumors were hiding. Well, then why not do it in the MR machine itself? Being in the MR would not be a high throughput procedure, office-based. It would be costly to take an MR machine offline for diagnostic purposes and make it an interventional procedure. And it's a division of good labor. Radiologists are excellent on interpreting images like MRI, and urologists perform these biopsy procedures in their office. And it's a great marriage to have those two together. So fusion just made sense. Now, the techniques part of this, there are different techniques for biopsies, for MR-directed sampling. Well, you know what? When MRI was shown to be the best imaging modality, why not do it in the MR machine, in the gantry or in bore? And a lot of institutions were doing that, especially overseas in Europe, and with good results. But as I mentioned before, expensive, patients didn't want that, time consuming. So next best thing would be have the MR information and then use your mind or cognitively navigate the needles to those parts of the prostates and those parts that the MRI says tumors could be hiding. This works, it's better than nothing, but not as accurate, especially in smaller lesions compared to software fusion platforms. That's where I'll finish up the rest of my lecture today, speaking about the techniques and the different devices for software-guided interventions, biopsies. A lot of them also give the capability of doing focal therapy. It keeps the biopsy in the hands of the urologist in his office or her office, allows opportunities for high throughput, and I'll go through all the systems in a moment. All this work really was internationally established, colleagues overseas in America. Our contribution to this was in 2015, where we did one of the earlier fusion biopsy studies for 1,000 patients. Drs. Turkbay and Brad Wood, who are at this meeting today, main contributors to this work. And in doing so, what they realized at the time was that, when we do a fusion biopsy, we find more aggressive, clinically significant cancer. And actually, if we just do the MRI directly, we find less of the low-grade cancers we don't want to see. So definitely a clear benefit, level 1 evidence. And as a result, when you use the fusion biopsy data to select your patient with different treatment options, surgery, surveillance, focal therapy, whatever it is, you're benefiting the patient's treatment decision than if you're doing using the information from a just 12-core blind biopsy, which can be very misleading. And as a result, really it's practice changing. This has been practice changing, and that mentor, quote unquote mentor, chair who said to me, MRI is magnetic resonance imagination. Why are you doing this, Peter? Last year when I got the AUA Distinguished Research Award for this work, he jokingly said to me, well, gee, aren't you glad you didn't listen to me? I said, sure enough, you're right. And really my heart's a source seeing, the opportunities for how we've changed the practice for the better for our patients, incorporating this type of research into our daily lives. And so fusion biopsies, we use it now after screening for PSA. And this may bring PSA back into the mix. I know really disparaged by the U.S. Preventive Services Task Force, because after the PSA, that blind biopsy was not the best treatment diagnostic algorithm. This fusion biopsy is. For those who don't have access to these devices, you do a 12-core biopsy and you miss the cancer, you're sure something's wrong, maybe it's there, you just can't find it. It's a clear path towards another colleague or friend or incorporate in your practice, but don't keep repeating those blind biopsies. We're using now for surveillance opportunities to better select patients for surveillance. And we use fusion biopsies now for focal therapy guidance, pre-op decision making, also for surgery too. So it's really changed how we practice medicine today. And what you'll see, for those who are not familiar with this, is this kind of split screen of an ultrasound image of the prostate and the MRI below. And they're linked or fused together. That's the fusion. So the MRI, a stagnant image acquired prior to the biopsy, moves in real time with the ultrasound probe in your hand or in a device. And here, this registration is spot on. As you can see here, there's a cyst on the MRI and a cyst in the ultrasound in the sagittal view. I put this on there for my colleague, Dr. Brad Wood. Not sure why, but he loves cysts. And whenever we do biopsies together, he gets very excited. He says that it's a good registration, internal fiducial marker. It confirms that we're in the right place. And, Dr. Wood's always correct, so I agree with him. But he loves cysts. And then going forward, this is a video of transperineal MR ultrasound fusion, where the needle passes through the ultrasound linked to the MRI. The coordinates are mapped. Nothing on the ultrasound would indicate this is a tumor, but there's a large tumor based on MRI characteristics. And the ability to biopsy where the MRI tells us is most likely where the cancer is can be done in the office with these fusion platforms. So I'm pretty confident I have a complete list of all the devices available US and overseas, and we'll cover each device as it relates to the route of needle placement, how it's tracked and navigated, the fusion opportunities, how the biopsies, ultrasound images are acquired, and the biopsy fixation device. Again, I apologize if it's not complete. If anything is left out, please let me know, but this is pretty close to it. UNAV, this is the machine that we kind of birthed at the NIH in our research lab. Opportunities to use this device in your office for biopsies, both transrectal, transperineal. We have an EM or electromagnetic sensor that's attached to the ultrasound probe, and it tracks it. This is based on the Faraday principle, and time will not allow me to go into details of what that means. But if you grab Dr. Brad Wood at the break, he loves to expand on how EM tracking works, and you can just grab him for that. Fusion, again, with the MRI or ultrasound, is not in the same shape You can, that's rigid registration. You can alter an image, elastically warp it with software to make it lined up, and this has the ability to do that. Many of them do. You require sci-fi or M-fire probes, and the needles can be stabilized. If it's transrectal, freehand. If it's on the perineal system, it could be a brachy stepper. It could be a freehand device on it, like on the probe, like a precision point device, or even just a trocar in the perineum works too. Artemis through Eigen, Canadian company, allows us to use same type of fusion, but with a different way of fusing. This is a mechanical arm. It's right here on the side. Otherwise, everything else probably about the same, and really, minor differences when you talk about registration, EM versus mechanical. The Eurostation from Coelis out of France, same thing, same type of system. Navigation, not EM or rigid, it actually uses the contours of the ultrasound. There's a three-dimensional sweep, uses that for image-to-image registration with the MRI, and also works very well. Many urologists have BK, kind of legacy ultrasounds in their system. And so this BK system uses a software package fusion called for MIM, and allows TP or TR, and then encoded stepper for the positioning. So again, this uses the BK ultrasound. Some of the other systems like UroNav, it can be any ultrasound you want. So that goes into the decision making about which one you want to purchase. This is actually now a robotic system, BioBot, or the Mona Lisa, and gives you really kind of semi-automated, physician-directed robotic application of the fusion platform for biopsies and for focal therapy. Navigo from UC Care actually has a suite of products. So again, TP or TR, EM tracking, freehand or stabilization, and they also include they call it the smart biopsy system. It's a nice way of actually having the needle acquire the sample, putting the sample into a container that orients the location, orientation of the specimen. It's a whole package that goes with the Navico system. Biojet, not to be confused with BioBot. Biojet, again, the smaller profile, really relies on this mechanical encoded stepper for navigation and tracking, rigid or elastic. Again, very similar features to the other devices I've discussed. From Virtual Navigator, the product from Italy, ultrasound incorporated into it for MR fusion. Again, does a wonderful job in this space. Biopsy from Germany, but again available anywhere really. Allows again this kind of encoded stepper. We saw that before on some of the other devices, elastic or rigid, TP or TR, and you can again have stabilization or freehand for your needle placement. So as you can see, again, a little bit of a dry talk in regards to these devices, very similar, but it's great to have all these choices. Toshiba has a platform, a Pleo Smart Fusion System, again, ultrasound, MRI, EM tracking, end-fire probes in this case, or sci-fire if you need it, and then Logique 9 is the GE option for their platform. Again, very similar to what I described before. The final one on the list would be the Hitachi system. Again, excuse me. Very similar, more of the same to prior systems. A great unit that allows TPTR, EM tracking, stabilization opportunities for diagnostic biopsies, focal therapy. Really comes down to the choice you make for your office. You do, you can't go wrong, because it's better than doing this every day, as we've done for decades. Swinging away at the prostate, hoping to hit that cancer, never knowing where you are. Finally, we have devices that can stop this madness. I want to thank, it's not just team science. Dr. Bradford Wood always likes to say it's family science. It's so true. Here's my family at work. Barry Turkby, who's at the meeting, you've heard already, and Brad Wood, who's also present speaking. What a pleasure to be here for 20 years with them, affectionately my work wives, as they say. And then I'll end with this. The course directors, Arvin George, Abhinav Sadhana, they overlapped as fellows with me at the NCI, and had to find the picture. This is like the class photo, right? Everybody has it in their department, and sure enough, there they are, bookends at the time. Didn't think they'd be having these courses, right? But they were working so hard, doing a great job, and just so proud of their accomplishments, their continued work in the field, and then the individuals they are training at their respective institutions at Hopkins and U Chicago. Again, we're always open for visitors and guests. Happy to host anybody. We have a wonderful hospital, a very special place. Couldn't think of anywhere else really to do this work for the past 20 years, and hope to have you all in Bethesda at some point. Thank you.